My name is Neil Strickman. I'm a clinical professor of medicine at the Baylor College of Medicine in Houston, Texas. I've been in practice since 1982. Today I'm going to talk on intravascular coronary lithotripsy, or IVL. And we'll talk about what is it, how does it work, the Disrupt CAD3 clinical trial. I'll show some cases, possible uses, and then the conclusion. So what is IVL? Well, as you can see here, it has a generator, a quick connect, and then it has the emitter catheter. And what it does, it has a miniature array of lithotripsy emitters to use at the local vascular calcium sites. Now, it's the only non-atherectomy technology that can deal with calcium. You can save the cost of the atherectomy device. You don't need an embolic protection, and it can treat deep wall calcium, thus allowing full balloon and stent expansion. How does it work? Well, if you look and see here, here is the compact regenerator, and it's rechargeable. You plug in the quick connect, and it's an enclosed integrated balloon, as you see there. There are the lithotripsy emitters. There are two non-emitters on each end, and then the emitters in between. It creates pulsatile sonic pressure waves to modify the calcium. And here you can see it here. The integrated balloon is then expanded, usually to 4 atmospheres, and occasionally I have seen it go to 6 atmospheres, but usually well expanded at 4 atmospheres. Now, the fluid in the balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. And here you can see it up against the wall. 3 kilovolts of energy travels through the wire to the emitters from the generator once per second, where acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. And here you see it up against the wall with the emitters firing. There is a small electrical discharge at the emitters that vaporize the fluid that's inside the balloon to create a rapidly expanding bubble that generates the pressure waves impacting the calcium at approximately 50 atmospheres, creating a small series of microfractures that increase the vessel compliance. And here are the microfractures created. And now when you're done, you can use the preferred treatment of choice, whatever you decide. It's good for concentric as well as eccentric calcium. Probably more microfractures occur in the calcified region. Now, when the heart rate is less than 60, it may capture the QRS and give you ventricular pacing. Here's the Disrupt CAD clinical trial from Dean Kiriakis from Cincinnati, United States. They had 384 patients, 47 is rolling, and planned for a 2-year follow-up. And then the key clinical and angiographic eligibility criteria are pretty standard for most trials. You have to have at least a medium ejection fraction of 25 or greater, vessel size from 2.5 to 4, lesion length less than 4, and concentric calcification. Typical characteristics, mostly male, diabetes, smokers, things that we see. But what I point out here is functional class 2 and 3 angina. Severe calcification in everyone, stent delivery in 99%. And what you have to note is that 55% of the time it required predilation because the balloon is somewhat bulky and you may need to predilate to get it there. And as you can see, there was 1 severe dissection, 1 perforation, and 1 abrupt closure after the final stent deployment. The 30-day MACE rate was pretty typical of most trials, TVR being around 1.6%. The Disrupt CAD3 trial success was achieved as those primary safety and effectiveness endpoints were met following treatment with the coronary IVL in severely calcific lesions. It increased vessel compliance. There was a large post-procedural area and excellent stent expansion. Here are just a few cases. Here is an LAD that was treated with a 2 pi by 20 IVL and a 3 by 24 drug-eluting stent implanted, as you can see here. Here is a circumflex with a very proximal severe calcification lesion treated with a 3.5 by 20 IVL and a 4 by 24 DES was implanted. Here's a right coronary artery that had severe calcification around the bend, treated with multiple regions of the same 3 by 20 IVL, and then a 3.5 by 32 DES implanted. What are some other uses that we have seen? Well, here, very typical. It started in 2016 by treating peripheral disease, and here is a typical calcific superficial femoral at the adductor canal that used the catheter. Here is an innominate artery calcific stenosis using the peripheral catheter 7 by 60 with an adequate stent expansion, as shown here, a 9 by 38 balloon expandable stent implant. Here is shockwave then for a critical left subclavian artery stenosis. The emitters are pointed out by the arrows. There's the critical stenosis as seen by the long arrow. And then finally a 7 by 38 stent was implanted in the left subclavian artery. Shockwave for carotid stenosis. The arrows show the severe calcific stenosis. The velocity was 425 over 110. A 4 by 40 actual peripheral IVL was used with adequate stent expansion as shown here. Here are the catheters that are available. The coronary C2 meeting 2 emitters, 10 pulses per cycle, 10 seconds each, thus 80 pulses. The peripheral, the large M5, 4 to 7 by 60, 5 emitters, 30 pulses per cycle, 30 seconds each, that's 300 pulses. And the peripheral small one for below the knee, 2.5 by 40, small vessels, renal, below the knee, 4 emitters, 20 pulses per cycle for a total of 160 cycles. So I conclude for shockwave that it is a very safe to use. If you compare it to orbital or rotational atherectomy, there is much less complication, dissection, perforation, or Bruch closure. The thing that's nice about it is the following. In the DISRUPT trial, success was achieved for primary safety and effectiveness with coronary IVL in severely calcified vessels. Coronary IVL performed pre-DES implant has an extremely low rate of major procedural, clinical, or angiographic complications. It can induce ventricular capture if the rate is less than 60. It's extremely useful for lesion modification, although it can be used as an end result in the periphery. And the relative ease of use for cardiologists makes it a safe way to achieve full stent expansion in severely calcific lesions, because time and time again, I hear the cardiologist say, it's a balloon, and we know how to use that. Well, I thank you for attending, and take any questions.
Thank you very much, Professor Strickman, for